Let's continue. All right. So we're going to talk about some about geriatric issues, some clinical problems associated with aging. So this is what we're going to talk about is actually aging in and of itself and problems associated with it, and just think about all the other possible clinical problems, chronic diseases, other issues that gets very complicated by these issues we're going to talk about with aging, okay? Because these issues with aging happens to everybody, okay? Nobody is spared aging and death, okay? That's actually the point. My point of today's lecture is that every person in any kind of clinical setting needs to really, really accept that there is no cure for aging and death. Okay, so this is something, these are constellations of problems that are going to happen to everyone, and they will happen to a much greater severity in people with other complicating problems, okay, which is almost everyone as they get older. So this, the content in this lecture is taken from a chapter in Harrison's Principles of Internal Medicine. This link will actually take you to this source. Access Medicine, do you guys know about Access Medicine at all? So Access Medicine allows you to peruse books and journals all collected by the same publisher, and Columbia's got a subscription to this. So this is something that you have access to that you should use, particularly as you're going into integration. You should also use things like PubMed, also things like UpToDate. Okay? All of these resources for getting further information are things that I highly recommend that you incorporate, because whatever habits that you can create during this period of time are going to be habits that you can potentially continue once you are actually working. Okay? Or you're no longer in school. So clinical problems of aging. So in younger adults, diseases tend to have more distinct pathophysiology with well-defined risk factors. Diseases in older people have less distinct pathophysiology, and they're often the result of failed homeostatic mechanisms. So everything all the normal physiology we've been talking about this semester, this is what, these are the normal homeostatic mechanisms, okay? The mechanisms for the maintenance of blood pressure, the mechanisms for the maintenance of blood oxygenation, right? All of these things for blood sugar, for in terms of the stress response, or whatever you're thinking about, these homeostatic mechanisms get disturbed as people age. And as a result, you start to see problems. And then on top of that, diseases will manifest very differently because of these changing homeostatic mechanisms. Causes and clinical manifestations become less specific and vary widely between individuals. Okay? Care of older patients demands an understanding of the effects of aging on human physiology and a broader perspective that incorporates what's called geriatric syndromes. Okay? So we'll talk about that in a moment, but geriatric syndromes are problems that older individuals are highly prone to. Okay? And we're going to focus on a couple of key geriatric syndromes. So population aging emerged as a worldwide phenomenon for the first time in history within the past century. Remember, I talked about vaccinations a while back, right? Does anybody remember, on average, how many years vaccinations has added to our life expectancy? About 30 years. Okay? So we are seeing a completely new phenomenon, which is a huge segment of the population being old, you know, and passing, dying in their beds instead of dying as a result of battle or dying from some disease that we didn't have a cure for. Okay? Governments and societies, as well as families and communities, now face new social and economic challenges that affect health care. While the number of children has remained relatively stable, explosive growth has occurred among older populations, especially the oldest. The number of persons aged 80 to 89 years more than tripled between 1960 and 2010. Okay? So we have a population today that's here to stay, and the healthcare challenges surrounding them, we're just now starting to fully understand. Okay? Many chronic diseases increase in prevalence with age, and it's not unusual for older persons to have multiple chronic diseases. Major issues with aging include increased disability. Okay? This is a major, major problem. Difficulty with activities of daily living, or ADLs. All right? It might seem really uninteresting, but it is extremely important, and it's a really, really big problem, particularly because as people need more and more help accomplishing these activities of daily living, there's very little resources for them to get them. Okay? And so family and spouses end up becoming caretakers, which ends up accelerating their aging often. Cognitive impairment, right? Increased use of healthcare resources and increased health expenditures. Expenditures increase with age, they increase with degree of disability, and they're highest in the last year of life, okay? And this is also something that you'll hear me say over and over again. You will cost the healthcare system, or your care will cost more in the last year of your life than the rest of your life put together. Okay? You will spend more on your care for the last year of your life than the rest of your life previous to that put together. Okay? And part of that is really a problem with how we as a society deal with aging and dying. Okay? So these activities of daily living that get impaired as people get older, things like personal hygiene, dressing and undressing, eating, transferring from bed to chair, voluntary controlling of urinary and fecal discharge, using the toilet, moving around, okay? And then there are some activities of daily living that we call instrumental, because while they're not fundamental functioning, they are things that will determine whether somebody can live autonomously or not. Okay, so whether they can live independently or whether they then need round-the-clock care. And it includes things like doing light housework, being able to prepare yourself meals, being able to take your medications, shop for groceries, use the telephone, manage money, and in this day and age, use technology. Okay? My mom is 70 years old, and she is an old 70 years old. And, you know, she does not like the computer, right? And she wants to do everything the way she's always done it, and it just doesn't exist anymore, right? So being able to use some kind of technology to be able to get by is also an important part of living independently. And this is, you guys have learned about the developmental stages of life, right? So this stage of life is, in Erickson's scheme of developmental psychology, in social development, this stage of life is independence versus, ego integrity versus despair. That is the basic crisis of old age. It's ego integrity versus despair. Now, ego integrity means that either you're going to be able to hold on to your sense of self, the things that make you feel like yourself, or you're not going to be able to hold on to those things, and you are going to be deeply depressed. You're going to have depression and anxiety, and you're going to have a lot of problems. Okay? So it's not a small thing to consider the basic activities that people have to do to be independent, because for some older people, not being able to live alone anymore means they lose everything. Okay? So that ego integrity versus despair, it's an important thing to keep in mind, and it's highly individual. You know, what that means for every person is very different. Systemic consequences of aging, they are widespread, and they are clustered into 4 basic domains. Okay? So systemic consequences of aging is a change in body composition, number 1. Your physical body changes as you get older. One of the key changes is a decline in lean body mass. Okay? Lean body mass includes muscle and visceral organs, the actual tissue of your visceral organs. That declines with age. Okay? Body fat percentage goes up as a result. Okay? It doesn't mean that you're gaining weight. It means that you're losing more lean body mass, so your percentage of fat ends up getting increased. Okay? Number 2, the balance between energy availability and energy demands. Okay? So basically how your body balances energy. Energy demands include whatever you want to do, all your physical activity in life, plus any kind of chronic condition you may have that requires the expenditure of energy to maintain you. Okay? So this idea that the food you consume and all the sources of energy that you get, how they then translate into being used by your body, there's a bit of an imbalance. Okay? And the result of that imbalance, that energy imbalance, is basically fatigue and difficulty completing tasks. You get tired very quickly. Number 3, we're calling them signaling networks, which makes it sound very obscure. But basically, our systems, like the endocrine system and the nervous system, that are responsible for maintenance of homeostasis, they are starting to falter. Okay? And when the endocrine system and the nervous system are not working properly, that affects the entire body, right? Because they are responsible for controlling and regulating and coordinating all body systems. Okay? So, for example, in someone without cardiovascular disease, without diabetes, as you get older, right, and you wake up from bed. So imagine you are your nice young self right now, and you wake up from bed, and you realize that you're late for class or you're late for whatever. You pop out of bed, you run around, and you get ready. Okay? Older people cannot change body position that quickly because the baroreflex, right, the reflex that maintains perfusion to the brain no matter what body position you're in, that's more sluggish as you get older because it involves both the endocrine system and the nervous system. Okay? So reflexes and homeostatic mechanisms start to fail as people get older. And neurodegeneration, okay, which is it includes brain atrophy. Okay? Neurodegeneration includes brain atrophy, and it includes a change in both structure and function of the nervous system. Okay? So these 4 basic things are the consequence of aging: a change in body composition, a change in energy balance, failing of these homeostatic systems, and neurodegeneration. And so these 4 domains of systemic changes over here are a result of aging. So we'll be returning to this flow diagram in a moment, but or a little bit later. But basically, aging creates these changes in the body, which leads to something called frailty. Now, frailty, we might have actually an image in our mind when we think of something frail, right? And probably when we think of someone frail, we can create an image in our mind. But basically, someone who is, so frailty in terms of aging is someone with extremely low resistance to stress, right? Someone who is very, very weak, someone who is essentially one stressor away from very rapid decline. Okay. Now, when people are old, when people are older, it does not mean that they're frail. Okay? Frailty is something that when it develops, it's really a sign of they're in the last stage of their life. Okay? So once someone develops frailty, they are highly susceptible to one or more of these geriatric syndromes. Okay? Gait disorders that can lead to falls, anorexia, malnutrition, extreme disability, disease susceptibility, so they're highly susceptible to certain diseases, or if they already have a comorbid condition, it can end up accelerating. Okay? Decubitus ulcers, urinary incontinence, sleep disorders, delirium, cognitive impairment. Okay? So once someone is pushed into a position of frailty, they very quickly can progress into these geriatric syndromes, and it can then very quickly lead to the end of their life. Okay? And I'll tell you a story later to wrap up everything that describes how someone who had chronic conditions as they got older, okay, they had one acute illness and it pushed them to frailty. And then from there, it was less than a year before they passed away. Okay? So you can kind of see how this is the basic landscape of aging. Okay? And so these things like a fall or like getting bronchitis one winter, right? Or contracting some other illness can actually put somebody from just being older to becoming frail. All right? And that's kind of what we want to avoid. We want, when you're treating somebody who is older, you want to avoid the progression to frailty. So these 4 domains of systemic changes during aging, there are different ways to assess them. Okay? So body composition can be assessed through physical exam, lab values, imaging, and some other assessment approaches. The basic energy balance, you can talk to somebody and ask them how tired do they get with different activities. You can elicit performance through physical exam, right? Neurodegeneration, physical exam is going to be very fruitful, as is imaging and some other tests. Okay? So we can assess somebody's level of physical impairment or level of aging by assessing these different domains of the systemic effects of aging. Okay? So a little bit more on these different domains. Body composition. Profound changes in body composition may be the most evident and inescapable effect of aging. Right? Your body is going to change no matter what you do. Over the lifespan, body weight tends to increase through childhood, puberty, and adulthood until late middle age. Weight tends to then decline in men between ages 65 and 70, and in women somewhat later. Okay? And what's interesting about this is if you're going to enter the last season of your life, and I'm not talking about your 90s, right? I'm talking like you getting past 65, 70. You're going to enter the last season of your life. It's actually better to enter it carrying a little extra weight than it is to enter it being extremely slender, okay? Because that last season of your life is when this energy balance problem, if someone has really very little body fat, they're going to have a hard time having energy reserves as they get older. Okay? So as people get older, you know, being obese is a problem, okay? But we're talking about the difference between slightly overweight and obese, okay? Being slightly overweight as you get older is actually thought to be better for people. But we have a really distorted view of what slightly overweight versus obese is. So look it up in the BMI thing. That's what we're talking about. Lean body mass, composed predominantly of muscle and visceral organs, decreases steadily after the third decade. Yes, you read that correctly. The third decade, 30. All right. So it all goes downhill after 30. Now it's hitting home, isn't it? Yeah, you and me both. So in skeletal muscle, this atrophy is greater in fast twitch versus slow twitch, okay? And fast twitch muscle tends to give us sort of that rapid muscle contraction, rapid power, okay? While slow twitch tends to be the kind of muscle that allows you to go on like a long run, okay? Fat mass tends to increase in middle age and then decline in later in life, reflecting the trajectory of weight change. Waist circumference continues to increase across a lifespan, a pattern suggesting that visceral fat, which is responsible for most of the pathologic consequences of obesity, continues to accumulate. Okay. Muscle strength declines with age. Okay. People get weaker and weaker with age. This decrease not only affects functional status, but also is a strong independent predictor of mortality. Okay. And what we found is that's very helpful for older people is to do really low impact strength training, okay, to try to slow the decline in lean muscle mass. It also helps slow the weakening of bones when people do strength training. And then the other activity that's extremely good for older people is anything that requires body awareness and balance. So things like yoga, tai chi, all right? Those are very, very good because it decreases the risk of falls. So this is the change over time as people get older. So in men versus women, okay? And basically you see the same kind of trajectory. Lean body mass is going down in both. Weight increases and then decreases after a certain age. Okay? Fat mass does the same thing. It increases and then decreases. And waist circumference actually continues to increase until the very end. We also see progressive demineralization and architectural modification of bone, resulting in a decline in bone strength. Loss of bone strength also increases the risk of fractures. Okay? So an older person falls, even if it's a small fall, they're more likely to have a broken bone. Okay? And then what becomes really problematic is if they have to be immobilized in order to heal, because if they're immobilized in order to heal, particularly if they, let's say you have an older person who falls and let's say they break a rib, it hurts to breathe, right? And so they're not going to breathe as deeply, and then they're more vulnerable for respiratory infections. Okay? So things really snowball quickly when people are older. Overall, compared with men, women tend to lose bone mass at a younger age and more quickly reach the threshold of low bone strength that increases fracture risk. All of these changes in body composition can be attributed to disruptions in the link between synthesis, degradation, and repair that normally serves to remodel tissue. Changes in body composition are influenced not only by aging and illness, but also by lifestyle factors like physical activity and diet. Okay? So you definitely will see people who are very old, but they look great, right? And they're active, and and they've been taking care of themselves for a long time. I heard this wonderful talk by a woman who is my age, and she describes herself, she works in aging science, and she describes herself as an old lady in training, that like the only thing, she's decided she just wants to abandon training for aesthetic purposes and just focus on training to be like a really badass old lady, which is a really smart move, right? Because that will maximize her ability to enjoy her life as she gets older. So then we're in this energy balance issue. So a person's physical fitness or energy fitness, it's defined as the maximal possible energy production over an extended period of time. Okay? So how much energy can you produce over a period of time is a description of your fitness. Okay? And that declines with age. Okay? So your ability to do work or create energy production declines with age. Energy production and consumption, measured indirectly by oxygen consumption, declines progressively with age, and the rate of decline is accelerated in persons who are sedentary and those affected by chronic illness. Okay? So your consumption of oxygen goes down as you get older, and it goes down even faster if you're sedentary and sick with something else. Resting metabolic rate declines with age, and it's only partially explained by the loss in lean muscle mass. Aging individuals with chronic illness expend more energy in a resting state. Okay? So someone with heart disease, someone with diabetes, someone with respiratory disease particularly, like COPD, they expend more energy even while resting compared to people who do not have the illness. This leads to a higher resting metabolic rate, contributes to weight loss seen with illness, and it's an independent risk factor for mortality. Okay? It's not well understood why, but old age, chronic illness, and physical impairment all increase the energetic cost of motor activity. Okay? So it costs more units of energy, more calories to do a particular motor activity as you get older. All right? And it's not well understood why. For this reason, sick, older individuals often consume all of their available energy performing the most basic activities of daily living, leaving them fatigued and mostly sedentary. Okay. Neurodegeneration. Brain atrophy occurs with aging after the age of 60. Atrophy proceeds at varying rates in different parts of the brain. Age-associated brain atrophy may contribute to age-related declines in cognition and motor function. In mild cognitive impairment, the atrophy has been found mostly in the prefrontal cortex and the hippocampus. And in fact, generally speaking, atrophy with old age is predominantly affects the prefrontal cortex and the hippocampus. Prefrontal cortex is that part of the brain that is your mini executive, right? It helps you regulate your attention. It helps you organize your tasks and manage your life, okay? And manage perceived stressors and things like that. And then, of course, hippocampus is learning and memory, right? Short-term memory. So these parts of the brain that are most affected by atrophy in older people are things that allow people to be productive, right? It allows people to be productive in the world. So this is something that if someone maintains a level of productiveness in the world, they will tend to be less affected by these changes. Does that make sense? So this is why my mother, who's 70, is a very old 70, while some of my colleagues at the School of Nursing who are over 70 are like running circles around me, okay? I'm not bashing my mom. I love her. She's great. Other changes in the brain of older people compared to younger individuals: less coordination between brain regions. So there's less communication and coordinated information flow between brain regions. And less localization of cortical activity during tasks requiring executive function. Okay? Now, what's interesting about these findings in terms of changes in the nervous system is that you can actually see these changes, physical and in terms of cooperation between brain regions, without any cognitive impairment. Okay? You can end up seeing atrophy. You can end up seeing a change in that less localization during executive function or less coordination, even when somebody's cognitive function is perfectly fine. Okay? So it's really all about how does this person and their brain adapt to these normal changes of aging. Okay? And again, just like the person who's been physically active and will have a less severe decline in their physical body, someone who is very mentally active is going to see less of a decline in their cognitive function. So brain pathology typically that's been associated with specific diseases like amyloid plaques and neurofibrillary tangles, considered a hallmark of Alzheimer's. Those changes have been found at autopsy in many older individuals who had normal cognition as assessed by extensive testing in the year before their death. Okay? So you can see someone after they die with a brain that looks like they've got Alzheimer's, but they were perfectly fine before the end of their life. And recent studies have shown that those individuals were more likely involved in learning new things and engaging in activities, right? One of the activities that was highly studied was bridge, right? Older people who play bridge, you laugh, but bridge is a really hard game, and there's a lot of strategy, right? And so people who played bridge, or people who knit, women who knit, or men who knit, if they're constantly learning new, what do you call that? Patterns, stitches, thank you. Constantly learning new stitches or constantly challenging their brain, those were the people, the knitters and the bridge players, who had just orders of magnitude better cognitive function. But their physical brains looked the same as someone with Alzheimer's. So a lot of plasticity in terms of, use it or lose it. And so here's the 5-year decline in mean volumes of different brain regions. And you can see that the prefrontal cortex is most affected, followed by hippocampus, parietal lobe. Okay? So prefrontal cortex and hippocampus are really important for executive function. Okay? So this is one of the sort of things that if it's going to go, it's going to be that sort of function. Now, the spinal cord also experiences changes after the age of 60, including reduced numbers of motor neurons and damage to myelin. The motor neurons that survive, they compensate by increasing their branching complexity and by serving larger motor units. So as motor units become larger, they decline in number at a rate of about 1% per year, starting at the 3rd decade of life. These larger motor neurons contribute to reductions in fine motor control and manual dexterity. Okay? So as you get older, you might notice that as people get in advanced ages over 60, they might notice that their handwriting gets a little bit more messy, right? And it's because these motor units are getting bigger, and so your fine motor activity is more challenged. Age-related changes also occur in the autonomic nervous system, affecting cardiovascular and splanchnic function. Taken together, age-related changes in the brain and spinal cord are thought to be compensatory, an attempt by the nervous system to reorganize and compensate for aging. For this reason, significant declines in functions are not always present in older individuals. Therefore, early detection of pathological decline requires actually careful testing. Yes, ma'am? So for all of this, so the decline is going to be there, right? But for all of these things, the more the person is practicing and engaging, the less severe the decline is going to be. And so their functioning in all of these categories, including fine motor, may actually be better than somebody younger than they are, right? Because they've been practicing more. But for them, they're going to notice that they're just, so if they're a musician, they're going to notice they're making more mistakes in this piece, or they're not creating the same finesse as they used to, or you know what I mean? They will notice the difference, but they can preserve quite a lot of their abilities with this constant practice. Yeah. And then these homeostatic mechanisms that start to fail as you get older, particularly endocrine and nervous regulation networks. Age-related changes often discussed individually, but in reality, these changes develop in parallel and affect one another. So some known interactions. Age-related changes in body composition causes and is in turn worsened by changes in hormonal and cytokine/adipokine regulation of energy balance, which, for example, higher fat mass, especially visceral fat, causes metabolic syndrome associated with lower testosterone and increased inflammation. Okay? So basically you get this interplay between these physical changes. So the change in body composition can exacerbate the malfunction of the endocrine system. Higher fat mass can lead to insulin resistance, and altered leptin adiponectin can promote neurodegeneration. Okay? Again, body composition affecting the nervous system. Increased inflammation, lower testosterone, and less IGF-1 associated with aging contributes to the decline in muscle mass and strength. And then finally, age-related neurodegeneration can affect hypothalamic and autonomic functioning, which in turn can affect nearly all homeostatic systems. Okay. So these things aren't happening independently of one another. They're sort of happening and triggering each other. So, bless you. So frailty is part of the phenotype of aging, okay? And it includes increased susceptibility to diseases, a high risk of multiple coexisting diseases, an impaired response to stress, okay? Including the recovery from acute stress, the emergence of geriatric syndromes, an altered response to treatment, high risk of disability, loss of personal autonomy. Okay? The aging phenotype may be the detection and treatment specific overlying pathological conditions make it difficult. Okay? So someone who is frail, it's going to be difficult to discern when they get different diseases. Okay? For example, an older individual who gets a UTI or pneumonia, the only sign or symptom that you can see sometimes is, that's right, a change in mental function, right? So all of a sudden they're confused, or they're not coherent, or they're not speaking in their normal way, okay? Or that's happening, and all of a sudden they seem really frail, right? But they're not coughing. They've got pneumonia, but they're not coughing, and they don't have a fever, and they don't have whatever. Okay? And the same thing with the UTI or urosepsis. And the reason behind that is that their immune function is depressed. And it's your immune reaction to pneumonia that causes you to cough and causes you to get fever. Okay? So in an older individual, it can be very difficult to discern when they've acquired a condition. Okay? But any kind of change, any kind of abrupt change in their level of functioning, right? They all of a sudden, over the course of a couple days, they look like a frail person. There's something going on, right? An extreme presentation of the aging phenotype is this term frailty, okay? It's really an extreme presentation of this aging phenotype. And frailty, in turn, can lead to or worsen geriatric syndromes. Okay, so this was, when someone gets to this frailty, they're then going to start to develop these geriatric syndromes. So frailty has been described as a physiologic syndrome characterized by decreased reserve, diminished resistance to stressors, and that result in a cumulative decline across multiple systems. Okay, physical signs of frailty. Physical signs of frailty. Weight loss, fatigue, impaired grip strength. Okay? They seem very weak. Diminished physical activity, and slow gait. Okay? So these are physical signs of frailty. The 5 signs of frailty are included in the Frailty Index, which has been shown to be a reliable predictor of 1, survival of community-dwelling older people. Okay? So there's actually a Frailty Index. You can quantify how frail a person is presenting. And that index, that number, is highly correlated to how long they'll live if they're living independently, right, in their apartments or whatever. And number 2, survival, length of stay, and discharge location in acute care settings. Okay, so in the hospital, whether they will survive and how long they will be in the hospital, and whether they will get discharged back home or discharged to a long-term care facility, okay, are all well correlated with the Frailty Index. So it's important to understand the potential interactions between frailty and pre-existing or newly emerging conditions. Okay? Pre-existing chronic diseases such as diabetes or congestive heart failure can trigger the onset of frailty in an aging person. Okay? It can worsen the condition, quality of life, leading to mortality. The presence of frailty in an older person can mean that any injury, disease, or impairment may trigger a rapid decline in health, precipitating significant disability or death. Okay? So, for example, an older adult who fractures a bone as a result of a fall is at very high risk of dying within the next 6 months. Okay? And so an older individual who has a fall and breaks a bone, right, or God forbid breaks a hip, they have a high likelihood of passing away within the next 6 months. Okay? So things that a younger person could rebound from, okay, older people just simply can't. Yep. Can you say that one more time? Yeah. Yes. So the question is about the nursing diagnosis, high risk of frailty and frail elderly syndrome. This is the same thing. This is what we're talking about, yeah. So you have somebody who, that could be somebody who is a little bit, who's older than 60 with a pre-existing condition, right? Or someone who had a pre-existing condition and then all of a sudden had a fall, right? They're high risk. Yeah, it's basically being older and experiencing any kind of new onset of stress. That they're going to be at high risk. So 4 main clinical consequences of frailty, which is connected to what we've been discussing. Ineffective or incomplete homeostatic response to stress, multiple coexisting diseases, and polypharmacy. Okay? That's a really big one, polypharmacy. Older individuals are often on just a crazy number of drugs, okay? Because they've got multiple conditions and they're, one condition is causing one problem, they take a drug for, which causes a side effect, they take another drug for that, okay? So polypharmacy is a real issue. Physical disability, geriatric syndromes. The geriatric syndromes include incontinence, delirium, falls, pressure ulcers, sleep disorders, problems with eating or feeding, pain, depressed mood. Okay? Dementia and physical disability are also sometimes considered geriatric syndromes. Okay. Low resistance to stress. At an early stage and in the absence of stress, mildly frail older individuals may appear normal. Okay? However, they have a reduced ability to cope with challenges, such as acute disease, trauma, or surgery. For example, acute illness involving a hospital stay is associated with undernutrition and inactivity, causing residual muscle mass to fail to meet the minimum requirement for walking, leading to disability that may be unrecoverable. Okay? So you can have an older individual who has an acute illness like a pneumonia. They get put in the hospital, and just being in the hospital and being in bed for more hours of the day than they normally would cause their muscle mass to decline, and all of a sudden they can't take care of themselves. And maybe they won't ever be able to recover that. Okay? So that's a huge consequence, to go into the hospital because you've got an upper respiratory infection, and to leave the hospital needing long-term care. Older individuals have a reduced ability to tolerate infections, due to diminished inflammatory and immune responses. Infections are more likely to become severe and systemic and to resolve more slowly. So infections are more likely to go septic. They're more likely to go systemic because their immune systems are not fighting them. A low resistance to stress should be taken in consideration when choosing treatment options and assessing prognosis. Treatment plans may need to be modified to enhance tolerance. Hospitalization and bed rest should be avoided. Infections should be prevented, anticipated, and assertively treated. Comorbidity and polypharmacy. Okay? So having multiple conditions and being on multiple drugs. Frailty increases the susceptibility to multiple diseases, and multiple diseases worsen frailty. Okay? They go back and forth that way. Comorbidity and frailty greatly complicate diagnosis and treatment. Clinical signs and symptoms of disease may be less clear when presenting with multiple comorbid conditions. Drug treatment planning is made more complex because comorbid diseases may affect the absorption, volume of distribution, protein binding, and especially the elimination of many drugs, leading to fluctuation in therapeutic levels and increased risk of under and overdosing. So people who have multiple comorbid conditions are more likely to have altered pharmacokinetics in terms of taking drugs, which means that the drugs sometimes can be ineffective or cause more harm than good. Okay? Patients with many diseases are usually prescribed multiple drugs, especially when they're cared for by multiple specialists who do not communicate, which is the basic state of our healthcare system. The risk of adverse drug reactions, drug-drug interactions, and poor compliance increases dramatically with the number of drugs prescribed and the severity of the frailty. Okay? What's very common is people are put on drugs and never taken off the drug, right? Even though maybe they don't need it anymore, but it just gets added to the rotation. Okay? And it's very hard for people. Our healthcare system is very bad at allowing us to have a medical home that remembers our care, right, and remembers our needs. We basically are doing that on our own, and we have varying abilities to be able to accomplish that. So, some general rules for minimizing the effects of polypharmacy. Always ask patients to bring in all their medications, okay, including prescription drugs, over-the-counter products, vitamin supplements, herbal preparations, okay? And you can tell how big of a problem you have with how big of a brown bag they bring you, okay? Screen for unnecessary drugs. Those without a clear indication should be discontinued. Simplify the regimen in terms of the number of agents and schedules. Try to avoid frequent changes and use single daily dose regimens as much as possible. Okay? Single dose daily regimens, because this is an older person. If they've got to take it twice a day, that's 2 opportunities to miss it. Okay? If they only have to take it once a day, they're more likely to be able to comply. Avoid drugs that are expensive or not covered by insurance whenever possible. Minimize the number of drugs to those that are absolutely essential, and always check for possible interactions. Make sure that the patient or available caregiver understands the administered regimen and provide legible written instructions. And most importantly, or very importantly, schedule periodic medication reviews. Okay, do it again at every visit. Make them bring in all their medications and go through it again. Okay, disability. Physical and cognitive function in older persons reflect overall health status and predicts health utilization, institutionalization, and mortality more accurately than any other biomedical measure. Okay? So how much they can do physically, what they can do mentally, determines everything. Okay? Will determine everything. Frailty, regardless of the criteria used for its definition, is a robust and powerful risk factor for disability. Disability occurs late in the frailty process after reserve and compensation are exhausted. Okay? So once someone is starting to display some disability, if they're not already frail, they are headed towards frailty. Interventions aimed at preventing and reducing disability in older individuals should have a dual focus on both precipitating cause and the systems needed for compensation. So, for example, fall prevention in older individuals should also include balance and strength training, okay, which will both be needed for the recovery from a fall if it occurs. Okay? So you're really setting them up to have as much strength as possible, okay, for in case anything happens. Okay. So we're going to talk about some geriatric syndromes, and we're going to focus on delirium, falls, chronic pain, incontinence, and anorexia. Okay? We're going to focus on those geriatric syndromes. So delirium. Delirium is different from dementia. Okay? Delirium is an acute disorder of disturbed attention that fluctuates with time. Okay? Dementia is a persistent change in mental status. Delirium is an acute change in mental status. Okay? It affects about 15 to 55% of hospitalized older patients. Okay? Can be transient and reversible, a normal consequence of surgery, chronic disease, or infection. Okay? Delirium may be associated with a substantially increased risk for dementia and is an independent risk factor for morbidity, prolonged hospitalization, and death. Okay? These associations are particularly strong with the oldest of the old. So having delirium, presenting with delirium, is a very bad sign. Okay? It's not a good sign. The strongest predisposing factor for delirium are dementia, any other conditions associated with chronic or transient neurologic dysfunction, okay, and sensory deprivation. So, okay. The clinical presentation of delirium is heterogeneous, but frequent features include. So these are features of delirium. A rapid decline in the level of consciousness with difficulty focusing, shifting, or sustaining attention. Okay. Cognitive change, rumbling, incoherent speech, memory gaps, disorientation, hallucinations, not explained by dementia. And a medical history suggestive of pre-existing cognitive impairment, frailty, and comorbidity. Okay. So this is an algorithm for the assessment and management of delirium in hospital patients, older patients. So upon admission, assess current and recent changes in mental status, right, and monitor mental status. And then also prevent, address risk factors, improve communication, improve the environment, early discharge, avoid psychotropic drugs, right? So we're both going to assess how someone's doing in terms of their mental function, and we're going to implement whatever we can to prevent impaired mental status. So in the case of delirium, you decide whether this is chronic, and then in that case, give them an evaluation for dementia. Or if this is acute, you do a cognitive assessment to confirm delirium. Okay? If you rule out delirium, then you need to rule out depression, mania, and psychosis. If you confirm delirium, then what you need to do is identify and address predisposing and precipitating risk factors, provide supportive care and prevent complications, and manage symptoms. Okay? So what we want to do is decide on hospital admission of an older person what is the current mental status, and let's prevent them from becoming delirious, and then ruling out things like dementia, depression, mania, psychosis, right? And then addressing the delirium as best we can. Falls and balance disorders. Now these are really, so all of these issues are very relevant for nursing care, right? All of these issues, the nurses are going to be dealing with these issues or these problems a lot more than other clinicians in the healthcare team, okay? And in terms of falls and balance disorders, the nurse is going to be highly liable for things like falls, okay? So it's very important to identify people who are high risk for falls and prevent them, particularly in an older person that a fall can end up changing their life very quickly. So unstable gait and falls are a serious concern in older adults because they lead not only to injury but also to restricted activity, increased healthcare utilization, and even death. Poor muscle strength, neural damage in the basal ganglia and cerebellum, diabetes, and peripheral neuropathy are all risk factors for falls. Okay? And that's not an exhaustive list. Interventions to prevent or reduce instability and falls usually require a mix of medical, rehabilitative, and environmental modification approaches. Patients with a positive history of multiple falls are as well as persons who have sustained one or more falls should undergo an evaluation of gait and balance to assess for Interventions depend on the factors identified, but often include medication adjustment, physical therapy, and home modification. And this is a really fascinating truism. Supplementation with vitamin D at 800 IU daily may help reduce falls, especially in older persons with low vitamin D levels. Yeah.
So with a fall evaluation and a gait evaluation, would that be, who would do that? A gerontologist, PT?
It probably either the gerontologist or the PT. So it's not necessarily, I mean, I think that the nurse and other care providers are going to do a more cursory evaluation, but a more thorough evaluation is going to require some specialized knowledge. Yeah. Okay. So in your family, right? Make sure that the old people in your family are taking vitamin D. Okay. So there's also an algorithm for assessing and managing falls in older patients. Okay. So we're going to ask patients about falls in the past year, right? If there's no falls, that's great. Recommend fall prevention, education, right? Strength training. We're going to do all this stuff to enhance that. If the answer is yes, they have had a fall, right? If they report more than one fall, right, or difficulty with gait, balance, yada, yada, we have to do a multifactorial fall risk assessment, which includes things like history of falls, medications, visual acuity, right? All of these things that are going to play into causing previous falls and repeated falls. If they've only had one fall in the past 6 months, right, check for gait or balance problems. If there's gait or balance problem, again, we do this assessment. Okay? And then based on our findings for the assessment, we can intervene, okay? We can modify the medications, we can treat the visual impairment. Okay? A lot of times, particularly in the home, I mean, avoiding falls in a hospital setting is obviously extremely important. But for preventing falls in the home, one of the most important and overlooked thing is actually environment, is actually the space. What is really common are throw rugs, right? So old people have throw rugs everywhere, and they bubble, right? Or so these sorts of things will cause people to trip and fall, particularly when they're not paying attention, particularly when they're tired, okay? So controlling the environment is very, very powerful tool for preventing falls in older individuals. Persistent pain. My husband's father is 92 years old, and he can take his finger and move it back and forth over that knuckle, right? He's got almost no cartilage left in his joints, and he is a very pleasant man who is in constant pain. So just every day of his life, his body hurts, and that's aging, right? That is aging. So pain from multiple sources is the most common symptom reported by older adults. Persistent pain results in restricted activity. It can depress the hell out of people. Sleep disorders, social isolation, increased risk of adverse events due to medications. The most common cause of persistent pain are musculoskeletal problems, right? Osteoarthritis, very, very common. But neuropathic pain and ischemic pain occur frequently also. For persistent pain, regular analgesic schedules are appropriate and should be combined with non-pharmacological approaches such as splints, physical exercise, heat, and other modalities. Okay? So, because relying on drugs to relieve pain is really difficult, because all pain medications, all analgesic drugs have problems. They have dangers. So relying on any of them can increase problems long term. But at the same time, we need to balance being alive with wanting to be alive, right? So controlling pain through medications and non-medication methods is very important. Education of patients and mutually agreed upon goal setting are important, since pain is usually not fully eliminated, but rather is controlled to a tolerable level that maximizes functioning. Okay? So you're going to work with the person to figure out what combination of things is going to control their pain to a tolerable level, because it's never going to go away. Okay. Urinary incontinence is another geriatric syndrome. Involuntary leakage of urine is highly prevalent among older individuals, particularly women, and particularly women who have had children, right? And has profound negative impacts on quality of life. Approximately 50% of American women will experience some form of urinary incontinence over a lifetime. Increasing age, white race, childbirth, obesity, medical comorbidities are all risk factors for urinary incontinence. Three main forms, the most common forms associated with aging: stress incontinence. Stress incontinence is essentially either a sphincter failure or a problem with the pelvic floor muscles. And stress incontinence is when you cough and you leak, or you laugh and you leak, okay? Or you sneeze and you leak, all right? And so it's very, very common in women. In men, if it's present, it's almost exclusively secondary to prostate surgery, okay? Because that's the only time they've got damage to the pelvic floor muscles. Urge incontinence is different. urge incontinence is the loss of urine accompanied by a sudden sensation of a need to urinate and an inability to control it due to muscle overactivity. So this is muscle spasms in the bladder causing this abrupt urge to urinate, and it's not controlled, so there's leakage. And then finally, overflow incontinence is characterized by urinary dribbling, either constantly or for some period after urination. The condition is due to impaired detrusor muscles, contractibility, or a bladder outlet problem, like prostatic hypertrophy in men and cystocele in women. Okay. So this is, you've finished urinating, but there's still urine coming out. And that's also we see in older individuals sometimes. Okay. So urinary incontinence is connected to disrupted aging process systems that contribute to frailty, body composition changes, and neurodegeneration. Right? Frailty is a strong risk factor for urinary incontinence. Older women are more likely to have mixed urge and stress incontinence than any pure form. Like any other geriatric syndrome, urinary incontinence derives from predisposing conditions superimposed on precipitating stressful factors like UTI or vaginal or uterine prolapse. The first line of treatment is bladder training associated with pelvic muscle activities like Kegel exercises. A long list of medications can precipitate urinary incontinence, including diuretics, antidepressants, sedative hypnotics, adrenergic agonists or blockers, anticholinergics, and calcium channel blockers. Whenever possible, these medications should be discontinued. Okay? So if you've got a patient with urinary incontinence, take a look at their medication list. Okay? They might be on one of these. Okay. So last geriatric syndrome is undernutrition or anorexia. Okay? And in the medical world, I mean, anorexia is refers to sort of a loss of appetite and refusal to eat. It's different from anorexia nervosa, which is a psychiatric syndrome, okay, obviously. Normal aging is associated with a decline in food intake that's much more marked in men than women. To some extent, food intake is reduced because of a decline in energy demands, a lower level of physical activity, less lean body mass, and less protein turnover. Other contributors to decreased food intake include loss of taste sensation, reduced stomach compliance, just doesn't fill as, stretches as readily, higher circulating levels of CCK, and in men, low testosterone levels associated with increased leptin. Okay, so a lot of things coming together to make people lose their appetite. When food intake decreases to a level below the reduced energy demand, the result is energy malnutrition. Undernutrition in older people is associated with adverse health effects, including impaired muscle function, decreased bone mass, immune dysfunction, anemia, reduced cognitive function, poor wound healing, delayed recovery from surgery, and increased risk of falls, disability, and death. Okay? So if people are undernourished, they are susceptible to all of it. Okay? And they're well on their way to frailty. Despite these serious potential consequences, undernutrition often remains unrecognized until it's well advanced because weight loss tends to be ignored by both patients and clinicians. So this is one thing that when you see your older patients, not only are you going to, so when you guys move on to becoming an NP, if you see your older patients and you're going to get them to bring in all of their medications, right? And you're going to do a medication reconciliation thing. And then you're also going to weigh them. And you're going to weigh them every single time you see them. And you're going to look for declines in their weight. Okay? Because it can be very insidious. Older people can lose weight insidiously, and then before you know it, by the time it gets caught, they can't make up the difference in terms of the lost muscle mass. Okay? Muscle wasting is a frequent feature of weight loss and malnutrition that's often associated with a loss of subcutaneous fat. Main cause of weight loss are anorexia, cachexia, sarcopenia, malabsorption, hypermetabolism, and dehydration, and in some combination. Okay? Cachexia. What is cachexia? Anybody know? What's that? Cachexia, yeah, it's like extremely thin. It's like muscle, it's like body wasting thin. I don't know what sarcopenia is. I'll get back to you on that. What's that? Oh, is that what sarcopenia is? Yeah. Okay, there you go. Patients and caregivers should be taught to record weight regularly at home. Okay, so not only are you going to take their weight, but you're going to have them follow their weight. Patients should be weighed at each clinical encounter, and record of serial weights should be maintained in the medical record. When an older person has malnutrition, the diet should be liberalized and dietary restrictions should be lifted as much as possible. Nutritional supplements should be given between meals to avoid interference with food intake at meals. Limited evidence supports the use of pharmacological intervention to treat weight loss. So one of the pharmacological interventions that's been helping older people to stimulate their appetite. That's right. Marijuana. Okay? Particularly where it's legal, where it actually is legal quite a lot in the West Coast. Okay? There's little evidence that intentional weight, there's a lot of pot smoking among older people. There's also a lot of casual sex happening among older people. I know that's hard to take, but older people in older communities, there's a lot going on that you might not know. There's little evidence that intentional weight loss in overweight individuals prolongs life. So this is also an important thing to hear. Weight loss after the age of 70 should probably be limited to persons with extreme obesity and should always be medically supervised. So again, if somebody is a little bit overweight when they get older, it's actually better for them to just stop trying to lose weight, okay? To hold on to that. Because that weight is actually going to help them in that last season of their life. Okay. I have one more thing to cover. Are there questions? I'm not done today, but are there questions about what I just went through? Okay. So it's not so.